Let me invite the next panel to come on up. Now I'd like to introduce the co-leads of the Prevention, Treatment, and Recovery Services Working Group. Dr. Jay Bott is Senior Vice President of and Chief Medical Officer for the American Hospital Association. I think he may not be here this morning. Is that correct? Yep, thank you. I want to acknowledge him. To my immediate right is Dr. Alonzo Plough, Chief Science Officer at the Robert Wood Johnson Foundation. And to his right is Dr. Andrey Ostrovsky, Chief Medical Officer and Senior Vice President of Behavioral Health at Solera. Following their presentation, we'll hear from the invited reactors. Immediately to his right is Judge Richard Creatura from the U.S. District Court in the Western District of Washington. Lest we not be too Washington, D.C. centric, this is Washington State, so we thank you for traveling here. And to his right is Mr. Daniel Sledge, a community paramedic with the Williamson County EMS Mobile Outreach Team. Let me let you begin.
Excellent. Thank you very much, and thank you to our reactors. I really appreciate you guys being here. So I'll be as brief as possible so that we have time for our reactors to react, and I'll run through the first two objectives. Alonzo will share the third objective, and I do want to preface that we very deliberately did not prime our reactors. We want them to kind of think on their feet and get that visceral response from them, so I appreciate you guys doing this exercise with us. So in terms of our prevention, treatment, and recovery work group, we have, if we actually click, I guess I have the slides here. Here we go. Our mission is to curate, develop, and disseminate integrated approaches to prevention, treatment, and recovery services for opioid use disorder, including for vulnerable and high-risk populations, with guidance for how to implement, scale, and sustain them. The three objectives that we will briefly run through and the associated activities are as follows. The first one is curate and disseminate the essential elements and components of the continuum of care for opioid use disorder, including highlighting systemic barriers to integrated and effective prevention, treatment, and recovery services. The second is to share best practices and bring awareness to the barriers to implement, evaluate, scale, and sustain successful prevention, treatment, and recovery approaches. And the third that Alonzo will be running us through is to accelerate improvements in prevention, treatment, and recovery care and services for vulnerable and high-risk populations. So for the first objective, we have several activities lined up over the coming year. The first activities are substantive bodies of work, and the fourth activity is really a wraparound means to disseminate those outputs. So the first activity is a discussion paper exploring gaps in the addiction treatment system and focusing on strategies to overcome barriers to change within the treatment system. The second activity there is a discussion paper outlining the continuum of care for opioid use disorder, including its entry points, criteria for different levels of care, and opportunities to enhance the integration of medical and social services across the continuum. Now, it's very important to note for this activity 1-2, much of this has already been put out there in the ecosystem, and this is largely going to be an effort to bring that information together and, importantly, to help to disseminate it. Activity 1-3 is a discussion paper on the critical transitions of care in pain management and opioid use disorder and how to best manage them. Not to bias folks with my own opinion, but I think that is one of the largest gaps in terms of identifying what are the transitions and recognizing just how important they are from a consumer journey, patient journey perspective. And then, as I mentioned, activity 1-4 will be the ancillary communication products, webinars, one-pagers, perhaps even we'll see if we get to social media there. But importantly, we need to make sure that the activities 1-3 are not just confined in, as one of the prior speakers mentioned, pointy-headed academic conversations. We need to make sure that these insights get shared with the people whom are truly affected by the issues and who can really impact change. For objective 2, this is around how do we at a systems level scale some of what is working and also what are the barriers to scale. And there's this activity -1, which is really 4 large activities within one activity, and that is developing and sharing a framework of elements for successful systems. Those elements include the following: capacity, so workforce development and sustainability; competency, the essential competencies of the actual workforce, which has some very important parallels with one of our prior groups around education. Quality of care. So the high quality aspects of care and metrics to track quality. A theme very important that was mentioned by our keynote speaker, Gary Mandel, and some of the work that Shatterproof is working on. And then the fourth, and absolutely not least, is compensation, payment to sustain high quality care. And important to note that while about a third of the U.S. healthcare system's somatic care dollars are tied into value-based payment, almost no dollars are tied into value-based payment in the behavioral health care space. In other words, they're almost entirely fee-for-service. So the incentive for providers is to just do more throughput as opposed to actually deliver on outcomes. And that fourth piece will help to cover that. And then activity 2-2 is an effort to try to address the issue that there are many different stakeholders trying to work on these issues. Often they are working in silos, and we want to at least identify who are the major stakeholders and hopefully offer them an opportunity to work together. So a nationwide stakeholder analysis and ecosystem assessment of who's involved, hopefully building upon some of that voluntary identification by organizations committing to work in this opioid collaborative organized by National Academies of Medicine. Before I transition over to Alonzo for Objective 3, I do want to point out that and commend, frankly, the National Academies of Medicine in taking some feedback for an idea that some of us had, which is to incorporate a very basic element of human-centered design, which is to include actual end users, actual consumers, people in recovery, people with opioid use disorder in this process of developing our outputs. And so we're actively working on developing an advisory group to provide feedback to some of the things that we're working on here, beyond just a once a quarter, if you will, reactor panel, but a more active discussion and hopefully co-development of some of these ideas. Alonzo?
Great, thank you. Objective 3 is to accelerate improvements in prevention, treatment, recovery, care services for vulnerable populations and high-risk populations. As everyone knows, substance use disorder affects the entire continuum of our society, but we know both in terms of prevalence and in terms of barriers to effective treatment, certain populations have more to overcome. So this part of our objective is to understand, as we think about broader systems improvement for substance use disorder, again with the eye on opioids, but going beyond, how can we make sure that those improvements also improve the life courses, prevention, treatment, and recovery of individuals who have been marginalized or faced significant barriers. We're looking at 5 of those populations: justice involved, veterans, rural adolescents, and individuals who inject drugs. Again, anyone who works in this field knows that there's intersectionality there, and the substance abuse involved, injection drug using veteran, will come as a package, and so this is not going to be so much 5 discrete papers, but it's going to be trying to understand what we know about what works to improve outcomes both in treatment and in recovery and prevention for this group. I think it's clear from our discussions to date, and we're a diverse group with lots of perspectives in this group, that the traditional evidence base is not there in the way it is for many other kinds of things, RCTs. But there is much evidence, and from my career in public health practice, much tacit knowledge in the field, in federally qualified health centers, in healthcare for the homeless programs, in the VA, of how you have learned to put systems together to work for these high-risk populations. So when we look for evidence to help inform these improvements, it will be evidence from that knowledge that resides in groups that work on these issues. As Andrey said, it will be knowledge that resides in individuals and families who have lived experience with this condition. And so these analytic action-oriented papers, I'll change the term from discussion paper, these analytic action-oriented papers are going to synthesize all of that information in ways that we think can help us understand vulnerability as it plays a role in substance use disorder even more broadly. So with that, turn it over to our speakers.
Perfect. And I want to charge our speakers to not hold back. And in particular, if what we're saying seems to resonate, please let us know. If what we're saying you don't think is going to have any difference, please let us know. We really value your candid feedback.
We're tough.
With that, Judge Creatura, what are your thoughts?
We're tough. We're tough.
You know, as a judge, I don't have any problem with it. There we go. Let me tell you what I do as a federal magistrate judge. I'm involved in the criminal justice system intimately down in the trenches. I see the more serious felony offenders at the beginning of the process, on initial arrest, supervision before sentencing, through sentencing, and before they're incarcerated. But I also follow offenders once they come out of the prison system, when they violate their terms of probation. I have made it a task of myself to also visit facilities regularly, and I'm chairman of our Prisoner Litigation Committee, which goes into each of our state facilities as well. We have over 2.5 million people incarcerated in this country. Many of them, more than a majority of them, have substance abuse issues. This is a significant problem that has led to our overpopulation of prisons. I can tell you that every day I have people with addiction problems that come before me, and I'm happy to say in the Western District of Washington that we have one of the highest pre-sentence release rates in the country. What that means is while they're going through the justice system, we try to return them to the community as long as they're not a risk of flight or a danger to the community. And if we can take steps to reduce that risk of flight and the danger to the community, then we're required to do that. And we do that through treatment for drug addiction. Now, Gary, you and I talked just briefly before this session, and he posed a hypothetical. What do you do with a 17-year-old high school kid who's gotten in over his head, has been treated with drugs for a minor injury and found himself addicted, and you find him in front of your court? Gary, I think you might have been giving me the hypothetical for Brian. I didn't realize that at the time. I can tell you that occasionally I see those criminal defendants in front of me, and in the past I have tried very hard to put them into a treatment program that is effective. But I can also tell you that we have been hamstrung by a lack of any quality ratings for those facilities. We have many families who are willing to spend tens of thousands of dollars to help their young man or young daughter make it through this opioid addiction, but they're throwing the money away because I can't tell. I mean, I can tell that the menu for their cafeteria is very good and they have a nice view to look out on a golf course, but nothing about the efficacy of the program. And unfortunately, many of them come out of those programs failing. With medically assisted treatment, we have found an evidence-based system that I think can treat many of these opioid addiction problems. Funding is a significant issue. If you want to know at the top of the chain, if you want to look for payors, we need to maintain Medicaid provisions for people that are outside of the prison facility. That has been a tremendous resource for us, for those people whose families or themselves do not have the financial ability to pay for treatment. Insurers, you need to take into consideration the fact that providing treatment for people who are in the federal or any criminal justice system is imperative. But I have to tell you that I have had a number of defendants, or at least several defendants, come to me and I offer them medically assisted treatment and supervision while they're going through the justice system, but they know they're going to need to spend time in prison, and they've refused it because they don't look forward to the idea of trying to withdraw from buprenorphine or methadone while they're in the prison system. Because almost without exception, our entire prison population of 2.5 million people do not have available drug treatment behind the walls. Now, Admiral Giroir, you made a bold statement. I don't know if you're still in the room. You made a bold statement that you are the government. This Department of Justice, each of the Department of Corrections of the various state facilities needs to recognize they need to let treatment behind the walls. Now, there are very small programs throughout the country, specifically in Rhode Island, which has allowed medically assisted treatment to prisoners, and it's been shown to be in the last 2 or 3 years an extremely effective program. And more importantly, when they leave the Department of Corrections for Rhode Island, they are allowed to continue their continuity of care, because unless you have continuity of care, it's not going to work. And so, for those of you who are members of the government, your charge is provide a continuity of care for the criminal justice system, because those people, not just the 2.5 million there, but the many more millions that are affected by criminal justice, are also sons and daughters, and returning to the community to move next door to you. And the only way to stop that recidivism, and the only way to improve the quality of their life, is to allow that continuity of care from the moment they enter into the justice system and long past the time when we hope they'll never return. And for those of you who are providers, medical providers, you have a very important function here, because I can't tell you the dearth of medical providers that are willing to go into our prison system and serve the prison community. I've talked to doctors within these correctional facilities. They are few and far between and are far overworked and underpaid, and their tenure is very limited. Why can't the more successful practitioners take a day out a month and go into the prison facility and provide evaluation and treatment? I can't even get a prisoner evaluated for opioid overdose or opioid treatment, because I can't get a healthcare provider to go into the institution to provide me an evaluation. And I don't feel like I can relieve them and bring them back out of the community safely without doing so. That is your charge as medical providers, to figure out a way to assist the Department of Justice and all the departments of corrections in providing medical care within the present facility. I could go on. When people leave departments of corrections and the Bureau of Prisons, a recent survey that I just heard last week said that those people are 20 times more likely to die on their first few weeks of release from prison. Why? Because they try to reuse, and because of a forced abstinence during a period of time, their tolerance is way down. They try to take at their same level before, and they die. People are dying as a result of the way we're treating them in our criminal justice system. And the only way we can do so is a collaboration of the government, the payors, and the medical providers. That's your challenge.
Thank you for giving us a lot of work to do, and if this mic could be dropped, it would be. That was brilliant. I really appreciate it. Daniel, I'm excited to hear your remarks, and I would love if you could share a little bit about your personal journey, because the fact that you're willing to talk about this publicly, which we should all be comfortable talking about it publicly, but unfortunately we live in a world where there's so much stigma that it's still so taboo. So I appreciate your bravery. I appreciate who you are, and I'm excited for your comments.
Thank you. Test. Okay. Hey, good morning. My name is Daniel Sledge. I'm a medic with the Williamson County EMS Mobile Outreach Team. I'm also a person in long-term recovery, and what that means for me is I've not had to have a drink or a drug since 10/24 of 2013. I feel incredibly blessed to be here and to be part of this, and I'm still somewhat in some disbelief. So let's see. I brought some action items, okay? And I love that you changed it from discussion to action-oriented papers, you know, because that's what we need. We know what the problem is, we know what works, and now we need action, right? And so these are related to the objectives of the gaps in treatment, the vulnerable and high-risk patients, continuity of care, and the stakeholders. And I narrowed it to my top three for brevity's sake, but here we go. Number one, more mobilization of treatment. The DEA should lift the 2007 moratorium on mobile methadone vans. It was created over fear of diversion. However, there are no data showing increased diversion or any breaches of the vans that were grandfathered in. Because of logistical constraints, especially with our patients with transportation issues or patients experiencing homelessness, methadone treatment's out of reach for so many of them. So we can drastically increase access to treatment by getting more, by getting the moratorium lifted now. Number 2 is to deregulate buprenorphine, or like the title of the recent article in JAMA Psychiatry suggests, X the X waiver. And we would still have training and resources for prescribers and robust training and resources, but we're in this continuous crisis. We're losing people at a disturbing rate. And so doing this would expand access to treatment. And if we look at the data from France when they did this, even though the data are a handful of years old, they're clear and they're compelling. In the article in JAMA Psych, the authors suggest that if we extrapolate those data to the U.S., we would reduce the mortality rate by 30,000 deaths annually. And that's incredible. And that's something we need to look at doing now. Number 3, and this is related to treatment and to continuity of care, would be to expand the role of telemed and continue to make provisions to the Ryan-Haight Act of 2008 so that it would be easier for providers, telemed providers, to prescribe buprenorphine. And from what I understand, the DEA have until 10/24 of 19 this year to activate the special registration for Telemedicine Act of 2018. This needs to happen as soon as possible. Tech has come a long way, and we've got these vast provider deserts, and patients have a hard time accessing treatment. So again, let's expand access to treatment. And like the American Telemed Academy suggested, let prescribers of any discipline be able to prescribe the buprenorphine without having to have first done an in-person exam. And also let the prescribers have DEA numbers in multiple states. Regarding stakeholders, always have input from the people we're serving, like you mentioned. Continually have focus groups and listen to the people we serve, and there always needs to be representation when discussing policy or other decisions by those whom we serve. It's like the saying, nothing about us without us. In closing, the biggest barrier to countering this overdose crisis is it's not transportation or patient caps that the X waiver has or housing or anything. It's stigma, like Mr. Mendel talked about. Stigma kills, literally, and it's really difficult to counter stigma because it's rooted in emotions, not necessarily science. But the good news is that we're all here together, and just like recovery, we don't have to do it alone. We don't have to try and counter this stigma alone. My wish would be that we never lose sight of the why of why we do this work. That we never, just become sort of used to looking at numbers and data and pie charts and stuff, but that we always remember the patients and families that we're doing this for. It's not easy, but it's worth it. So that's it. Thanks.
thank you so much. I really appreciate your input and look forward to discussion afterwards. Thank you.
Well, let me thank you. If there's a word that comes to mind thinking about this panel from you, Alonzo and Andrey, really inviting discussion on this, it was courage. But I think courage was even better manifest by Daniel sharing your story and your advice. And Judge, the clarity with which you spoke is really a model for public servants and statesmanship. So please join me in thanking this terrific panel.